Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hey everyone, I am the Millennial Mechanical Therapist. Today I want to talk about a pretty cool case that I had in this past week and a half or so here. Because of a couple things at work, we have been getting a little bit more of the OT side of things here, and we've been seeing a lot more fingers, wrists, hands, things along that line. So to my dismay, one day I walk in and I have an index finger on my schedule, and I was kind of taken aback because that was a whirlwind in school and I have not seen much hand therapy in my career yet. So I made the quick decision to just treat it like every other joint in the body, which ended up being a really good idea. So the gentleman comes in and he status posts MRSA infection in his finger. He described an injury at work in which he cut his finger. Real tough dude, super glued it back shut and just kept working. Ends up he gets a staph infection in there, and he's been going through medical management to eliminate that infection, but meanwhile he has severely limited range of motion in his finger. So he has that infection site on the lateral aspect of his PIP, and when he comes in, it's still markedly visible where that infection was. You know, the area is still raised a bit, it's still pretty pink, pretty red, but from all of his subjective reporting, he is clear of infection and he has been eliminated that. He's off antibiotics and things like that. So we go through a mechanical assessment of it. We find that he has weakened grip strength by about 15 pounds less than his opposite side. The injury occurred on his dominant side, so that's a pretty significant change in his grip strength. His PIP specifically, his flexion range of motion is quite limited. He's only able to bring his finger down to about here until he starts to feel symptoms, and he can push it to maybe about there. Extension is not limited at all. He's able to go. It's a little bit uncomfortable as he goes. He can even get that full overpressure, but nothing like flexion. So we go through the mechanical assessment. I have him extend his finger actively, and it doesn't really do much. So I have him passively take it to end range, and in about 10 repetitions, he actually increased his pain and felt worse. After we did that, we checked his baselines, and his flexion did not improve. It actually worsened a little bit. Because of that, let's switch directions. We're going the wrong way if this is a derangement. Take him into flexion. He goes, well, I produce it each time, no worse. He keeps going, he keeps going, he keeps going. As you would kind of expect, his flexion gets better. I mean, if he's flexing it, he should get a little bit more range of motion, but it wasn't a drastic improvement. So I go through those, and we add overpressure to flexion. Same thing kind of happens, produced, no worse. Gets better flexion, but nothing remarkable. Kind of what you'd expect from just stretching it. At this point, I'm starting to go, well, is this just a traumatic situation, or is he really a derangement? Well, let's thoroughly exhaust the motions that are at the finger. Now, the intention of the joint is to be mostly sagittal plane movement, of course, but you do have a little bit of wiggle room side to side. You can kind of gap and compress those joints in a lateral fashion. Because he has this infection on the lateral aspect, it was pretty large, and in my mind, in a biomechanical sense, he probably gapped that side quite a bit. Now that surely affected all of the systems, whether it was his nervous system, his biomechanic system, musculoskeletal, things like that. Everything was affected by that. But what I first started thinking is, well, he's got that obstruction from there. Let's close that down and see if something's changed in there. So what I have him do is to manually provide some abduction, some abduction to that finger in a way, at least the glide of that. So he goes through about 2 sets of 10 of that and goes, I feel a little bit better after doing that. His flexion improved in a more remarkable sense. You know, he had started about there, and now he's actually getting closer to about there. And I, well, hey, we might be onto something here. So I have him do another set. Nothing really changes. So what I have him do is I actually have him impart that glide and go into flexion. As we go through that repetitively, his flexion becomes almost full. Great outcome, really cool. Now you could definitely make the case that we just did a mobilization with movement. That's fine, whatever. I went through the mechanical assessment and got to that point. Maybe if you have been Mulligan trained, you would have gotten there quicker. Good for you, that'd be awesome. But the idea here is that by going through that mechanical assessment and just treating a joint like a joint, I was able to at least get to that answer. Now, if we fast forward about a week and a half, I saw him this morning. It was the 3rd time that I've seen him. On day 2, he reported an 80% improvement in his condition. Perceived improvement, self-benefit there. So it's subjective, but it's still a good number. Today, he comes in, he's like, hey, I can go all the way. His grip strength is now improved by about 25 pounds, and it's 5 pounds stronger than his contralateral side, which puts him back into a dominant phase for his dominant arm. And I just kind of looked at him and said, do you need any help now? Are you good? Do you feel like you can go back to work and things like that? And he was like, yeah. I picked up a bunch of stuff. I did a bunch of work yesterday with my dad needed some help building the shed. And well, if you're building the shed, I think you're going to be able to go back to work. And he said, yeah, probably. So today I kind of left it open. I said, if you need anything, give me a call. He's going back to his physician soon. I said, if something weird comes out of that, give me a call and come back in. But right now, I'm good with you. I mean, your strength improved drastically in a week and a half. You obviously haven't lost strength. You have just had some kind of inhibition to the muscles, and that's returned. So I want you guys just take that with any of the odd situations that you're going to see coming in. You know, like I said, maybe it was a mob with movement that really helped him, whatever you want to call it. It still helped him. And if you got there quicker, that's fantastic. If not, if you are mechanically minded, I would still encourage you to go through that whole assessment and find out what actually helps. You know, that's what I had to do. And it took him 3 visits to go back to work, so it's great. I think this case, more than anything that we've done before, really kind of ingrained to me the idea that you got to move your patients early, you got to move them often, and you really got to move them to end range, regardless of which plane it's in. Until next time, guys, take care.